I'll start with a simple topic, that is the basic, that is ANS, that is your autonomic nervous system. This is the basis, and then we'll see how it goes further. Okay. So,
Okay, ma'am.
you know, in physiology and anatomy, we have divided autonomic nervous system into sympathetic, parasympathetic. You remember?
Yes, ma'am.
But in pharmacology, what we are going to do is we are going to divide it into two other systems based on your drug targets. Okay. So drug target wise, if you divide it, it is divided into cholinergic and adrenergic. Okay.
Okay, ma'am.
You can note it down also. As we go on, I'll go slow so you can take notes along with me. Okay.
Okay, ma'am.
Okay. So we are dealing today with the first part, that is cholinergic part of autonomic nervous system. Okay. So this cholinergic transmission is a neurohumoral transmission either at synapse or a neuroeffector junction. A neuroeffector junction is nothing but a neuromuscular junction. Okay. In which acetylcholine acts as a humoral agent or a neurotransmitter in simple terms. Okay. So the transmission of action occurs across the joint. Okay. So to make this simple for you, what are the different sites? You know, there are so many sites. You have a parasympathetic neuroeffector junction, you have an autonomic ganglia, then you have somatic myoneural junctions. Just to simplify where all you get acetylcholine in the body, there is a diagram here. Okay. So when we start with somatic, you have a motor neuron, say your medial nerve or your ulnar nerve. Okay. It goes till your skeletal muscle, correct? So how does it reach?
Yes.
The nerve, when it reaches, what neurotransmitter goes through? It is the acetylcholine. Okay. So if you tell your median nerve to act, it will release acetylcholine at the end of its nerves, which will go and stimulate action potential. Okay. You remember the neuromuscular junction which we read in physiology?
Yes, ma'am.
Yeah. Similar to that, you have an acetylcholine getting released at neuromuscular junction, which will go and stimulate your skeletal muscle. Okay. So this acetylcholine, we have noted now, it occurs at the end of muscle plates. It also occurs at ganglia. What are the ganglia it occurs at? Parasympathetic ganglia and sympathetic ganglia. Okay. So all your preganglionic neurons release acetylcholine. Okay. But postganglionic, only two places you can see. Correct? Acetylcholine is here and acetylcholine is here. Okay. So in total, where all it goes, first one is we saw here, your neuromuscular junction. Your median nerve goes and it attaches to some muscle. At the end of the muscle, acetylcholine is released. Then all your preganglionic parasympathetic and preganglionic sympathetic. Okay. Postganglionic, we had only two. One here and one here. Simpler. So this is preganglionic. I'll just repeat. All this is preganglionic, correct? This is a ganglion. Okay. If you want me to simplify it, I get acetylcholine. One is your somatic NMJ. Next, in your autonomic, all the preganglionic places, and postganglionic in two places. Where all? One, I have cholinergic postganglionic, that is there in the sympathetic, and cholinergic postganglionic in parasympathetic. Two places postganglionic and all the preganglionic. Okay. Why am I stressing this again and again? Because this is voluntary. Okay. But these two are
Sorry, I didn't hear you.
This one is voluntary. Okay. The neuromuscular junction, the somatic one. Can you hear me now?
Oh, yes, ma'am. Yes, ma'am.
But these two are involuntary. Okay. So that is why it is important to know. Okay. So cholinergic receptors, where all does acetylcholine act? Those receptors are divided into muscarinic and nicotinic. Okay. So like we saw just now, you can see the M written there. This M, this is nothing but muscarinic. Okay. You see the N written here. This is nothing but nicotinic. Okay. So Why is it divided like this? Because the muscarinic is involuntary. Okay? And while nicotinic is predominantly voluntary. Okay? So, in the muscarinic receptors, you have 3 subtypes. Okay? M1, M2, M3. While nicotinic, there are 2, NM and NN. Okay? So, muscarinic M1 is present in the GI tract and some parts of CNS. While M2 is present in the heart. M3 is very important. It is present in the eyes, the blood vessels and the smooth muscles. Okay? So all these places, acetylcholine will go and stimulate muscarinic receptors. And all these places, acetylcholine will go and stimulate the nicotinic receptors. Okay? So we'll quickly revise. ANS is divided into cholinergic and adrenergic. Cholinergic means the neurotransmitter is acetylcholine. Acetylcholine can act on muscarinic receptors or nicotinic receptors. Muscarinic receptors are involuntary while nicotinic receptors are voluntary. Okay? So if this is voluntary, that means whatever your median nerve supplies, all your skeletal muscles, your ulnar nerve supplies, all your skeletal muscles, all of them have nicotinic receptors. Okay?
Okay, ma'am.
We go ahead. Now, how did this acetylcholine come? How did it come to the nerve ending is the real question. Okay? So your terminal, your axonal terminal of a nerve, they contain huge amounts of mitochondria. Okay? So this acetyl-CoA is synthesized in these mitochondria. Okay? So then choline is taken up from the extracellular fluid into exoplasm by active transport. Okay? Then the final step in the synthesis occurs within the cytoplasm. So to make it easier, I'll just show you this diagram. So acetyl-CoA comes here and it becomes acetylcholine by attaching to choline here. Okay? So acetyl-CoA attaches with choline to become acetylcholine. Where does the choline come here? It comes from outside, from the ECF. Okay? So it goes inside and then it combines with acetyl-CoA to form acetylcholine. Once this acetylcholine is formed, it is stored in vesicles. Okay? Once the vesicles are formed, whenever you say contract to your muscles, your arm muscles or your foot muscles, they will release acetylcholine, which will go to your neuromuscular junction and act on your motor end plates. Okay? And this will cause an action potential. Okay? So, now just tell me, your name is Nidisha, no? If I'm not wrong.
Yes, ma'am. Nirisha.
Nidisha, now you tell me, sir, when do I not want muscle to act? So, we are dealing with pharmacology. We want to give drugs so the muscle does not act. Why will I do not want to act muscle? Why will I not want? You getting my question or should I repeat it?
Yes, ma'am. Got it.
See, normally I want everybody to be active. So when do I want the patient not active? When he is in the OT, correct?
Yes, ma'am.
I want to give paralytic. Correct? So that time, I block these receptors. So acetylcholine cannot come here. Understanding?
Yes, ma'am.
Sometimes there are some diseases where I want the muscle to overact. They are not acting only. It is the opposite of this. They are not working only. I want them to act properly. So that time I'll give more and more of acetylcholine. What are those diseases where I want muscles to act? Some muscular disease can you think of where the neuromuscular junction is affected? Can you think of any disease where the neuromuscular junction is affected? There is something known as Myasthenia Gravis. Do you recall?
Yes, ma'am. Myasthenia Gravis.
What happens in Myasthenia Gravis? the acetylcholine receptors have antibodies to them, correct? So there are very less number of acetylcholine receptors. So I want more and more acetylcholine in the neuromuscular junction. Okay. So that means this is just the opposite of this. Here I want the patient to relax. Here I don't want the patient to relax. Okay. That is why it is important to know how to keep acetylcholine in a balanced state within the neuromuscular junction. Okay. So, when normally, how does acetylcholine come to the neuromuscular junction? It gets synthesized at the axonal terminal by combining acetyl-CoA with choline to form acetylcholine, which gets stored in vesicles. Okay? Whenever the nerve is stimulated, the vesicles release acetylcholine into the neuromuscular junction. So this acetylcholine then goes and sits in your motor end plates and causes muscle contraction. Correct? So
yes,
now,
ma'am.
how long can it act? Someday it has to stop, no? So who stops the acetylcholine? There is an enzyme called acetylcholine esterase. Okay, this breaks acetylcholine to choline and acetate. Okay, so choline again goes back and the same cycle continues. Okay, so if you want, you can note it down. You can note this down that acetylcholine is packaged into synaptic vesicles at high concentration by carrier-mediated transport. Then it is released by calcium-mediated exocytosis at neuromuscular junction. Okay. Then what happens? Acetylcholine acts on nicotinic receptors to open cation channels, producing rapid depolarization. So this leads to action potential in muscle fiber. Simple? We are clear with the physiology?
Yes, ma'am. Yes, ma'am.
Very good. So more about this enzyme. We told no, acetylcholine can't be there always in the neuromuscular junction. It has to stop working someday. So to stop working,
ma'am.
acetylcholine
Esterase.
Okay. So it is, where all is it present? It is present in cholinergic nerves, autonomic ganglia, neuromuscular and neuroeffector junctions. Correct? So what does it do? It puts water inside acetylcholine. Then it hydrolyzes it, leaving behind acetic acid and choline. Okay. So now that cholinergic synapse, the released acetylcholine is hydrolyzed by acetylcholine very rapidly. This again occurs within 1 millisecond. Okay. So this is just for your theoretical sake that there are two types of acetylcholine esterases. There is one is the true cholinesterase, acetylcholinesterase. One is the pseudocholinesterase. It is important to know the difference, but it is very theoretical. So what I'm going to do is I'll pass on the same PDF to these people here at Blue Pen Online, so they can give you the whole presentation. So you can make notes out of this. Okay. Suppose I'm going a little fast, you can make notes out of this. Okay.
Okay.
So now you tell me, we have effects on both muscarinic and nicotinic, correct? So we have just completed nicotinic. At nicotinic, what will it cause? It will cause muscle contraction, correct?
Yes,
so guess what will happen if muscarinic is stimulated? What might happen? Where all did we see muscarinic? We saw muscarinic M1, M2, M3. M1 we saw in GIT.
GI tract.
And some CNS. M2 we saw in heart. M3 we saw in eyes.
Okay. Blood
then,
vessels.
Correct. Blood vessels. Okay.
And smooth muscles.
Correct. Smooth muscles. So we need to know if acetylcholine goes and sits on M1, what happens? If it sits on M2, what happens? If it sits on M3, what happens? Okay. So in the heart, what does it do? It causes bradycardia or AV block. AV block is, it slows the SA node. Okay. So you remember the big nerve called vagus nerve?
Yes,
the 10th spinal nerve? That is
Yes, ma'am.
parasympathetic. So that releases this acetylcholine and causes bradycardia and AV block. Okay. Blood vessels
Okay, ma'am.
causes vasodilation. So your blood vessels become big. GIT, it increases peristalsis. Okay. Then bronchus, it causes spasms by bronchoconstriction. And glands, very very important, it increases the secretion from all glands. And eyes, constriction of pupil due to contraction of iris muscles, also known as ciliary muscles. Okay. So these are the effects on muscarinic receptors, M1, M2, M3. So GIT, I have increased peristalsis. Heart, I have bradycardia, AV block. In the eyes, we have pupillary constriction. It becomes small, meiosis, because of ciliary muscle contraction. And then blood vessels, I have vasodilation. Smooth muscles in the bronchus, it causes what?
Spasm.
Correct.
Bronchoconstriction.
Bronchoconstriction. So you tell me one disease where bronchoconstriction is very fatal. They are not able to breathe. What is that known as? Bronchospasm. What disease bronchospasm occurs? Asthma. Okay.
Okay, ma'am.
So now you tell me, just apply logic. If you give a cholinergic drug to asthmatic patients, it will just kill them, no? Because
Yes.
choline will go and cause bronchoconstriction. So what are you supposed to give in asthmatic patients? You are supposed to give anticholinergic. Simple.
Yes,
Okay.
ma'am.
So pharmacology is very very simple. You just need to know the mechanism behind each one. So I'll just draw right here that ANS we divided into two parts. That is your cholinergic and your adrenergic. Okay. Cholinergic further we divided into muscarinic and nicotinic.
Nicotinic.
Okay. So muscarinic, now we have three effects: M1, M2, M3. Correct? So now
Yes,
we need to
ma'am.
know whether in one condition should I give cholinergic or should I give anticholinergic. This is all we have to read. Okay? Just like how we saw nicotinic. In nicotinic, where will I give cholinergic? We just discussed here. We discussed, no? Paralytics and myasthenia. This is nothing but
Yes, ma'am.
to give. Here you will give anticholinergics, which will block here so that choline doesn't act. Here you will give cholinergics so that choline acts. Okay?
Yes, ma'am.
You're getting confused? Let me know.
No, ma'am.
Okay. So next, what are the cholinergic drugs? That means I want M1, M2, M3 to be affected. I want choline to act. These are drugs which produce actions similar to that of acetylcholine, either by directly interacting with cholinergic receptors, they are known as cholinergic agonist, or by increasing availability of acetylcholine at these sites. How do they increase? They inhibit acetylcholine esterase. Okay. So I'll try to explain to you again. So now I have only 50 packets of acetylcholine. Okay. But I want to excite this muscle. How will I do it? I will either give 75 from outside, or I will tell this acetylcholine esterase, stop working. Don't break down whatever acetylcholine is there. Let the same 50 packet work again and again here only. Correct? So either I give
Yes,
something that is similar to acetylcholine, which is known as cholinomimetics, or I inhibit this. Okay? Simple?
Yes, ma'am.
Okay. So first group of drugs is cholinergic agonists. Okay? Which are divided into choline esters and alkaloids. Okay? You don't need to memorize all this separately. You can just memorize it together. Okay? So first one is our simple acetylcholine. Next is methacholine. carbachol, bethanacol. All have this col in them. That's how you have to remember. Acetylcholine, methacholine, carbachol, bethanacol.
Carbachol.
Okay. Alkaloids
Okay,
are muscarine. Very, very important is pilocarpine. Okay. Then aracholine. Okay. So this is choline esters and alkaloids which go and act just like acetylcholine in the neuromuscular junction. Okay. So
Okay, ma'am.
see, now you have comparison between them. You have acetylcholine, methacholine, carbachol and bethanacol. So they have compared it. How does it act? All of them act, if you see, more on muscarinic receptors. Can you say? Very less on nicotinic receptors. Okay. Especially methacholine, if you see, they are very selective on the action of CVS. While carbachol and bethanacol are selective in GIT and bladder. Okay. So how do you
Okay.
remember what does acetylcholine do? Okay. How do you remember it? There is a mnemonic called sludge. Okay. So whenever you give increased acetylcholine in the body, okay, increased cholinergics in the body, okay, that time what happens? There is salivation, there is lacrimation, okay, then there is urination, there is defecation, also known as diarrhea, and there is increased GI peristalsis, and there is emesis. Okay, so these are the effects of acetylcholine in our body. Excessive acetylcholine. I have more than normal, all this will happen. Okay, so that is how you remember what it is. Okay, so out of all this, I told you to remember one important drug, that is pilocarpine. So pilocarpine is used in the eyes. Okay, it causes contraction of ciliary muscles, thus causing miosis. So you have pupillary constriction, it becomes small. Okay, so it is used for what? It is used to decrease intraocular pressure in open angle glaucoma. Okay, it has a short acting time, only 4 to 8 hours it will act. What are the other uses? You can put those drops, and after you test for refraction, you remember whenever you go and get your spectacle checked, they dilate your pupils. So that
Yes,
will be
ma'am.
there for so many hours. It will be there for 12 hours. But if you feel that it shouldn't be there for 12 hours, it should come down quickly, that time they give pilocarpine. Okay. And then it also is used to break adhesions between the iris and the lens. So this is your cholinergic drugs, one part, cholinomimetics. The other part is anticholine esterases. So I want to continue this in the next